You are listening to Go to Health Media. To reach Jonathan Marks or his guest expert, you may send an email to jonathanmarks@gotohealthmedia.com. You may also visit and subscribe to the website and show at gotohealthmedia.com. And now, back to this week's show. Welcome back to Go to Health. This is Jonathan Marks, your host, and we're talking today with Dr. Orli Petter. She is a postdoc certified in clinical, social, and neuropsychology. In addition to psychotherapy, her focus on neurofeedback and neuromodulation has resulted in what she refers to as accelerated trauma treatment. And what I want to talk about in this segment of the show is the different options for treating trauma and what Dr. Petter prefers and why she prefers it. So I want to get more into how we treat people in trauma and what are the best ways to do so. So why don't you define for us again, Dr. Petter, what is trauma as you define it as a professional?
Well, we look at, as a neuropsychologist, we actually do brain imaging generally. And we specifically look at a quantitative EEG, and that looks at networks that are then normatively compared across people the same age and the same gender, depending on the database. And there are certain predicted brain networks that can go awry when you're traumatized. So we look at it as a neurological event. Other people may look at, interference in attention, nightmares, hair trigger responses to things, depression, anxiety, dissociation. Those are the way the symptoms look on the outside. So that's what it is. And that's different than if somebody's stressed. And technically, according to DSM, you don't even make a PTSD diagnosis for at least a month after the traumatic event.
Okay. A brief definition, DSM is
the Diagnostic Statistics Manual that all mental health professionals are supposed to use to bill for insurance.
Got it.
Those are the two ways that you can look at it.
Dr. Petter, what you've just described is two ways of looking at trauma, and you're calling it basically something happening in the brain that is an abnormality. That is not necessarily visible on the outside, but it's definitely happening in the brain. And this is what you study.
Yes.
Okay.
Because usually it is also visible, but since with DSM, it's a cluster of symptoms, somebody may or may not have one or the other, and you really want to know what to treat. When you look at the brain, you can see better what's going on.
Okay. So what are some of the common ways of treating trauma? And I'm not talking about using neuromodulation or whatever, but I mean, is talk therapy useful? Is it helpful? Tell us about that.
Well, it can be. So that used to be, when I first volunteered for the Red Cross to help in disaster relief, that's what was being done. It was mainly a kind of brief talk therapy. Mm-hmm. But what they found was that a third of the people actually got worse.
Wow.
For that type of treatment. So that wasn't very effective. You didn't want to make people worse. And some people get worse from talking about it, especially if it's an intense trauma. Other people, they can't talk at all when they're traumatized. It just brings up too much. And there has been a study that was done by Bessel van der Kolk, who is one of the original trauma researchers. He and Judy Herman actually founded the field, that the linguistic center of the brain goes down when someone is traumatized. And so oftentimes they can't even talk. So talk therapy could either make things worse, or it can be totally not helpful because they're unable to, or we are unable to speak when we're in certain types of traumatic responses.
Mm-hmm. And so this all depends on the individual, as you said before. But one of these two responses is pretty common.
Yeah, usually today, well-trained trauma therapists will not just begin with talking. You have to do an intake, so you have to get some sense.
Mm-hmm.
But usually what you do is you want to go directly in some way into the nervous system
Hmm.
and relax the nervous system so that you're not re-triggering somebody so much.
Right. So let's talk about how do you go in and relax the nervous system in some way? What are the different ways of doing that?
So before we talk about that, I just want to give a caveat though.
Okay.
You don't want to relax it so much so fast that then the trauma material can just come rushing in.
Hmm.
So there really is a technique of being very, very delicate, especially in Israel with the very severe trauma patients. You want to really be monitoring very closely and very carefully how aroused they are and try to balance that. And I
Mm-hmm.
can talk more about the details of how you do that, but that's the goal. And so some of the ways, for instance, at one of the trauma centers at Boston, one of the things they'll do just manually is they'll have the patient tap on one of the vagus nerve. So the
Mm-hmm.
vagus nerve is a cranial nerve
Mm-hmm.
that goes into, it's like a net in the body, and it goes into the visceral organs, the various visceral organs.
Mm-hmm.
And counterintuitively, when it's activated, it relaxes you.
Mm-hmm.
So at some of the trauma centers, what they'll do if somebody can't talk, let's say if they were just in a very severe accident and it was so traumatizing to them, they're like in a kind of state where they can't talk, then what they might do is just have them just tap just like that.
On their chest. Huh.
Yeah, because the cranial nerves, the vagus nerve, one of the places it stops at the very top is right in the heart. So you can get at it right there.
Interesting.
And you can just do this. You can tap 100 times in a minute. So it's very fast and it has a pretty rapid result. I mean, people will notice it. And then you can do the other side too.
And what is the result that people experience?
It's an amazing result, actually, because what you'll see is people who couldn't talk before all of a sudden will be able to talk. Their nervous system will calm down enough because you're activating the vagus nerve, and it'll calm them down enough where they're going to be able to put words together and make a coherent story and a cohesive story about what happened. Because one of the things that happens when people are traumatized as well is if they can talk, their story is not coherent, it's not chronological, it's all over the place. Which, by the way, I do want to say, because this is something very important to me, people who are traumatized, their stories oftentimes are not believed as much as the person who perpetrated the trauma. Because that's one of the signs that we look at, because their brain is dysfunctional in a certain way where the stories come out incoherent, not cohesive, not chronological. Things that are minor might have a big meaning, like his smell. I remember his smell. Whereas the perpetrator of the trauma is very smooth. She is not traumatized. And so you can tell a very cohesive and coherent story. And a lot of times the judges or the public can get fooled by that.
Let me ask you, if I tap myself on the vagus nerve, does that help resolve my anxiety if I'm anxious? Is that safe to do?
Yeah.
Okay. So that's a good practice for when you get anxious.
And there's many other kinds of, call them psychological first aid techniques that you could do without fancy devices. Everything will help a little bit. There are certain kinds of breathing exercises, for instance, that you can do. Because as you're stressed, of course, you're not breathing properly anymore.
Right.
And all of this has been empirically researched, and trauma therapists should be using these things initially. But for people who are more seriously traumatized, not just stressed, that's where we come in and we add different neuromodulation, neurostimulation devices.
So let's talk about that. What is neuromodulation, neurostimulation? How do you do it? Is it invasive? Does it hurt?
We don't do the invasive kind.
Okay.
Usually there's just the people that do the invasive ones are people that for decades they have not been able to calm down, and they can actually go and get surgery and put an electrode on their vagus nerve.
Oh, wow.
Have it stimulated all the time. That's almost never necessary. That's very rare. It's done right here down the street. But usually that's not necessary. Usually with the kind of techniques we have today, we're able to avoid that. And how it works is, keep in mind the way that our neurons communicate with each other is through patterns of electrical current. And one of the ways that we can check to see how the brain is functioning is through kind of hacking the code of that electrical communication in the brain. And we can see that certain networks or certain parts of networks might be slower or lagging, or it might not be in phase with other parts of the network, or it might be going too fast, or it might not have enough energy. You know, all these different variables that can be happening. And we know what it should look like. We know the range of normality. So depending upon how the person is impacted by the traumatic event, we can go in there and actually add the type of energy that they need.
Oh, really? Specific? You can add a specific type of it. Wow, that's pretty incredible. Well, let's describe neuromodulation or neurostimulation. How is it done as you do it?
So I think I have actually right next to me, I happen to have this here because I like to use this sometimes while I'm watching TV. So this is just a coil of, it's called PEMF, pulsed electromagnetic frequency. And this is, you can set it to various types of frequencies, and you can layer the frequencies so that it'll pass through bone or blood or whatever, you know, whatever it is you're wanting to do. And I don't have it with me right now, but there's like a hat if you wanted to put it on your head, and it's Velcro, and you can just stick it on. Now this is a little home unit, so it's not what we use professionally in the office.
Right.
You can stick it on the place that needs it and just kind of give it a field of energy. So that's one thing that's done.
And when you say the place that needs it, I'm assuming that's as diagnosed by you.
Right.
It's not going to be very successful if somebody just tries to do it at home on their own when they don't really know what they're doing.
Yes, you can. Ideally, what we want is we want to be able to look at your brain to tell you specifically what you need and where to put. This is just one of the devices, but there's many different other devices and different types of energies as well. So we could recommend which type of device would be better, meaning which type of energy would be better. And we could tell you where it should go, because for instance, with anxiety, there's many different networks that can create anxiety in somebody. And if you just do it generically, like, oh, well, the generic idea about anxiety, for instance, is there's too many beta waves, there's too many fast waves, and so we just want to slow you down. Well, that's true for some people, but for other people, they actually may have anxiety because they have too many slower waves in the front of their brain. That's not inhibiting, you know, the back fiery part. And in a case like that, if you're just self-diagnosing, you could be actually using one of these devices and making yourself worse. So ideally, we like to actually see what's going on first. And then there are also some networks that just have a genetic component that you're not going to be able to help as much. And we could know with that type of component that this kind of energy is not only not going to be as useful, but it actually could irritate the person. It could make them more irritable. So those are the caveats, but nothing bad is going to happen if you try a device and you get irritated. Then you'll know, okay, I'm not doing it right.
Right. So how is it that you do the diagnosis of what kind of stimulation needs to be done and where it needs to be done? What's the process you go through in the office?
So for the diagnosis, we actually do a QEEG. So we actually put a cap on, we put 21 leads on their head, and we look at and see how their brain is communicating.
And from that, you can get a readout and then make a diagnosis of what kind of stimulation is needed with what kind of device and where on the brain. what's the range of ailments that you use this for? Is it just trauma, or do you use it for a broader set of psychological symptoms?
It keeps increasing every year as more and more research comes out.
Mm-hmm.
But right now, we use it for anxiety, we use it for OCD, because again, there's about 4 different networks that can go awry that can create obsessions and ruminations and compulsions. We use it for addiction, depression, the different types of anxieties that we already talked about, ADD.
Interesting. And your practice is located where?
We're in Beverly Hills.
Okay. And if people are not near Beverly Hills, do they want to look for this kind of therapy? What do they ask for? What do they go to a psychologist or psychiatrist and ask for? What are they looking for?
Well, they would ask for neurostimulation, which is different than neurofeedback.
Okay.
So there are more people that do neurofeedback than do neurostimulation. So neurofeedback is you put electrodes on to measure the brain, and then there's a feedback that someone gets that tells them when their brain is making a certain type of frequency.
Okay. And then neurostimulation is, by contrast, what?
By contrast, neurostimulation is something where we actually add the energy.
Okay. All right. So if people are looking for this kind of therapy, they want to ask about neurostimulation. All right. So we're talking with Dr. Orli Petter. She has a practice in Beverly Hills, California. She's a specialist in trauma treatment, plus many other kinds of psycho and social treatments as well. And in the next segment of the show, we're going to be talking about her Israel Healing Initiative. It's a very fascinating project where she wants to go over with neuropsychotherapists who are specialists in trauma going over to Israel to treat patients directly, and train psychotherapists over in Israel, as well as recruiting a group of psychotherapists in the United States to provide telehealth counseling for Israeli patients. We'll be right back. You are listening to Go to Health Media. To reach Jonathan Marks or his guest expert, you may send an email to jonathanmarks@gotohealthmedia.com. You may also visit and subscribe to the website and show at gotohealthmedia.com. And now, back to this week's show.